There are several impulse control disorders, so let's begin with the first one, which is intermittent explosive disorder. The police recently arrested a 24-year-old psychiatric inpatient after he beat up another patient, causing severe injury to the other patient's head and neck area and requiring more than 100 stitches. When asked why he assaulted the other patient, he replied, "He took my potato chips." Now, what's essential of this case is that this is an individual who is unable to resist an aggressive impulse that resulted in the serious destruction of property or assaultive acts. And what's essential in these types of disorders is that the act is usually out of proportion to the stressor. So if we go back to the case and look at it, all that the individual did was steal potato chips. And what did the individual do afterwards? He assaulted him, requiring numerous stitches. So the stressor and the act that follows, the act is always out of proportion to the stressor. The problem with intermittent explosive disorder today is that certain groups of people are outraged that they're using road rage, for example, as a type of intermittent explosive disorder. So you could be an individual that is okay, but every once in a while some cab cuts you off and you react out of proportion to the stressor. That would be a perfect example of road rage, and that's where intermittent explosive disorder is basically similar to that type of scenario. Now, as far as the risk factors for intermittent explosive disorder, as you can imagine, this is going to be affecting men much more than women. Why? Because of the assaultive nature of the disorder. You could have a genetic linkage. A lot of times patients with these disorders could have seizure disorders, could have any kind of encephalitis, could have also some type of brain dysfunction, which would be the cause of their disorder. They tend to have low levels of 5-hydroxyandoleacetic acid because, if you remember, low levels of 5-HIAA were linked to two things. One was suicide, the other one was aggression. Also, patients could have problems with the limbic system and/or testosterone. However, as the patients get older, what you tend to find is a lessening of the violence. So therefore, some of these symptoms or the violence tends to burn out. If you do a physical and psychiatric exam, you might find some neurological soft signs, but that seems unlikely most of the time. The EEGs are usually normal. The psychological tests are usually normal. So what do you find? What you probably find is a patient who has a terrible work history, a terrible social history, probably lots of problems in relationships, probably lots of marriages and/or divorces, and of course, problems with the law. The treatment of intermittent explosive disorder could be manyfold. You could give the patients mood stabilizers, you could give them antipsychotics, you could give them beta blockers, or you could give them SSRIs. There's still no FDA-approved drug for the treatment of intermittent explosive disorder. So probably on the test, this is not a treatment-driven question, but it's probably a diagnostic-driven question. And when you do psychotherapy, try to do it in a group setting and make sure that you are not alone in the room with all of these individuals. As far as the medical differentials, what we're looking at is epilepsy. We're looking at any kind of brain malfunction because of a tumor, some degenerative diseases, or even any kind of endocrine disorders. As far as the psychiatric differentials, we're looking at antisocial personality, borderline personality disorder, any kind of drug use, as well as schizophrenia.